Welcome to The Explainer. Today, we're diving headfirst into a truly fascinating, highly complex medical mystery, sarcoidosis. We've got a fantastic micro to macro journey ahead of us. We'll be looking at the core mystery of sarcoidosis, the cellular immunopathogenesis, granuloma pathology, clinical phenotypes, diagnosis by exclusion, and finally the nuances of treatment.
Part 1. The Sarcoidosis Mystery. Let's start by figuring out what we're actually up against here.
It's literally a 150-year-old medical whodunit. First described way back in the late 1800s by Jonathan Hutchinson and Caesar Boenick, sarcoidosis is basically our own immune system completely overreacting to some unknown environmental trigger. And this happens in people who are already genetically susceptible. What's crazy is the transmissibility of this immune response. We've seen it in organ transplants and historical tests using human tissue homogenates. That strongly suggests there is definitely an antigen at play, but the exact trigger, still incredibly elusive.
So, by definition, sarcoidosis is a systemic inflammatory disease characterized by the formation of non-necrotizing granulomas. Now, while this rogue inflammation can target almost any organ in your body, everything from your skin to your heart, it hits the lungs in over 90% of cases.
Moving on to Part 2, cellular immunopathogenesis. To really grasp what's going on, we need to zoom way in and map out the exact cellular cascade driving this disease.
This whole cascade happens in clear, sequential steps. First, that mystery antigen is presented via the major histocompatibility complex, or MHC for short. This kicks off a massive CD4-positive T-cell response. Crucially, this response is polarized to a Th1 phenotype, which means it's pumping out high levels of specific cytokines. Ultimately, this chemical alarm belt draws macrophages and monocytes straight to the site of inflammation. Now, a really key point here is that altered T-regulatory and Th17 cell responses are thought to be the reason why the body just can't shut this inflammation down, or why, in some cases, it progresses all the way to fibrosis.
This initial spark is brilliant yet devastating. The innate immune response releases cytokines and chemokines that basically act like a magnet for adaptive immune cells. Once the antigen is recognized and presented, it kicks off a highly coordinated, relentless loop that amplifies oligoclonal T cells.
As that inflammation spreads, we get the absolute hallmark of this disease, the granuloma. Now, this isn't just random, chaotic inflammation. No, it's a tightly packed, highly organized fortress of macrophages, epithelioid cells, and multinucleated giant cells, which literally form when epithelioid cells fuse together. And wrapping up the whole shebang is a tight, well-circumscribed rim of lymphocytes and fibroblasts.
Which brings us to Part 3, granuloma pathology. Let's stay at the tissue level for a moment and examine the specific pathology of these cellular fortresses.
The absolute make-or-break point here is distinguishing between the tightly formed non-necrotizing granulomas of sarcoidosis and other types. For example, an infectious granuloma, like you'd seen tuberculosis, is caseating, meaning it's full of abundant necrosis or dead tissue. Sarcoidosis granulomas, on the other hand, rarely have any necrosis. So, if a pathologist looks at a sample and sees abundant necrosis, they immediately pivot and start hunting for an alternative cause, like an infection.
The stark contrast between these tissues is wild. On one hand, you have the structured, highly organized shape of the sarcoidosis granuloma. Contrast that with the highly necrotic, caseating tissue characteristic of an infectious disease like TB. Telling these microscopic battlegrounds apart is absolutely vital for nailing down the correct diagnosis.
All right, Part 4, clinical phenotypes and organs. Now that we've explored the microscopic battleground, let's zoom back out to the macro level and see how these granulomas actually affect patients. The clinical presentation is just incredibly diverse. We're talking everything from totally asymptomatic lung nodules to severe, life-altering systemic issues. We see cutaneous manifestations like skin plaques, neurological disasters like cranial nerve palsy, especially hitting the facial nerve, and even life-threatening cardiac involvement like heart block or heart failure. Plus, patients might present with acute hypercalcemia. Why? Because those granuloma macrophages actually go rogue and produce unregulated calcitriol, which is the active form of vitamin D via an enzyme called 1-alpha-hydroxylase. Oh, and we absolutely can't ignore the massive systemic burden. Up to 80% of patients suffer from debilitating multifactorial fatigue and a really high prevalence of depression.
Since the lungs are almost always involved, clinicians rely heavily on scatting stages, which are based on chest X-ray patterns. These stages track the landscape of the disease, moving from bilateral hilar lymphadenopathy all the way up to widespread architectural distortion and fibrosis. But
And this is a big but. While these stages describe what's happening right now, they don't necessarily predict future disease progression or activity.
Because it's a systemic disease, patient archetypes vary wildly. Take Lofgren syndrome, for instance. It hits fast and hard, with an acute onset of fever and painful skin bumps called erythema nodosum. But surprisingly, it actually has an excellent prognosis and often just resolves spontaneously without any immunosuppressive therapy at all. Contrast that with lupus pernio, a chronic disfiguring skin condition causing violaceous plaques on the nose and cheeks. It's often seen in African American females and is a major adverse prognostic factor, usually linked to a much rougher clinical course with things like pulmonary fibrosis and bone cysts.
Moving to part 5, diagnosis by exclusion. Because sarcoidosis acts like a chameleon and mimics so many other things, getting to a diagnosis is a really rigorous process.
Diagnosis literally relies on exclusion. Clinicians have to act like medical detectives. Even if they biopsy a tissue and find those non-necrotizing granulomas, they still have to rule out an extensive list of mimics. We're talking infectious mimics like tuberculosis and fungal infections, other inflammatory diseases, and even malignancies that can trigger local granulomatous reactions. The truth is, the diagnosis of sarcoidosis is almost never made with absolute certainty. It's made by systematically proving it isn't anything else.
Finally, part 6, treatment and management. So, once all those mimics are out of the picture and sarcoidosis is confirmed, how on earth do we treat a disease when we don't even know what causes it?
Well, here's the harsh reality. There is no cure. Because of that, our entire clinical focus shifts. Eradication is off the table. Instead, the goal is suppressing that granulomatous inflammation, preventing permanent, irreversible organ damage, and improving the patient's quality of life by alleviating those debilitating symptoms, like the severe fatigue and neuropathic pain.
Management becomes this incredibly delicate balancing act. You have to weigh the severe risks of irreversible organ damage against the significant toxicities and side effects of first-line corticosteroid therapies. If steroids fail, or if the side effects are just too much, clinicians will pivot to second-line, steroid-sparing agents like methotrexate or azathioprine. You definitely treat when there's worsening shortness of breath or dangerous impending organ damage, but on the flip side, you observe and wait in cases like asymptomatic stage 1 disease. Why risk high toxicity for a condition that honestly has a very high rate of resolving on its own?
Which leaves us with a really fascinating thought to wrap up this explainer. With elusive environmental triggers and such complex genetics at play, could the key to curing sarcoidosis actually lie hidden within our immune system's own regulatory failures? Until we finally identify that mystery antigen, understanding our own immune system's miscalculations might just be the ultimate key to solving sarcoidosis once and for all. Thanks so much for joining me on this deep dive.